Hello, this is Carlos Cáceres. Welcome to all of you to this first webinar of the series that we have organized as a network for multidisciplinary studies on ARV-based HIV prevention. We know actually some of you are very early in the day. As our presenter, David Glidden, who is in San Francisco at 7 a.m., and some of you are very late at night. So we all thank you very much for your effort to be here, and definitely this seminar has had a very warm welcome around the world. We have more participants than expected, so we're happy about that. It's actually a merit of the topic of this presentation. Definitely this is a key paper by Susan Buchbinder and Dave Glidden and co-authors, and Dave, as the biostatistician of that team, has been fundamental in the development of this work, and has been very kind to join us for this first webinar. The idea of these webinars is actually to generate a level of discussion that perhaps hasn't been possible so far, and we would really like to promote that discussion beyond the countries where actual possibilities of communication about PrEP have been sufficient, and probably that is the case of the United States, of perhaps Canada, the UK, Australia, but in many other countries that's not possible, and that's what we are trying to generate through NEMUS, the possibility of people around the world, including lower and middle income countries, to actually have more access to information about ARV-based prevention. And at this time of history, probably we are putting an emphasis on pre-exposure prophylaxis, because this is a topic that hasn't been sufficiently discussed, and it is a topic that probably can make an effort, can make a difference in with regard to combination prevention in many places where HIV incidence continues to be very high. So just to mention, all our participants will be in mute, just to make it feasible for the webinar to go on, because the sound, the interference will be high. So we will, you have access to a chat room, and you will be able to write your questions throughout the call, and also throughout the talk and after the talk. So after the talk, we'll try to group the questions to make it easier for Dave to respond to those questions. Then you will also, or Dave is going to talk about, just after I'm discussing this, and we have to thank very much our colleagues from many of the networks working actively on the promotion of access to new technologies. I mean, Mitchell, Warren, Jim Pickett, Robert Reinhardt, not the AVAC, the Microbisat network, and also our colleagues from WHO, who and particularly people working in the regions, and some of program directors, the HIV program directors around the world, and actually the members of the NEMUS International Advisory Committee, who also have helped us organize the meeting with their respective networks. So I won't extend myself in talking, and if we are ready, I will let Dave speak. So actually, I'm not, let me just check. Okay. We can, Pedro, can we actually have Dave speak?
Sure.
Okay. Professor David Glidden is the main biostatistician at the iPrEx trial, and okay, and uh, he has been very kind to join us this morning. Okay, thank you very much.
Good morning.
Dave?
Yes. Good morning.
Okay.
So I'm happy that there is interest in this topic that I'm going to talk about today. I'm going to talk about some work that was done by my colleagues and I using the iPrEx data. In particular, this was work in collaboration with Susan Buckbinder, but everything that we do is made possible by the hard work of the entire iPrEx team. So what we've tried to do with the iPrEx data is cull some of the lessons about what populations are likely to benefit from an offer of PrEP, and in addition, think about what kind of populations need to be reached in order for PrEP to have a broad public health impact. This talk is one that I gave at CROI this year. It's partly specific to the population of iPrEx, men who have sex with men and transgender women. But in addition, I think about what are some of the broader lessons about populations likely to benefit from PrEP. This is work that was published in Lancet Infectious Diseases a couple of months ago, and I believe that with your webinar invitation, you were provided with that paper and perhaps also with the commentary by Dr. Jared Baton of the University of Washington. So I'd like to start out by looking back over the last 3.5 to 4 years as a series of trials have come in with information about the intent to treat efficacy of PrEP across the trials that have reported. Here I'm including both trials that included oral Truvada and oral tenofovir, as well as those that have included tenofovir gel. And it's striking, as I graph it here, how much that efficacy has varied across the different trials, from the nearly 75% efficacy of Partners PrEP with oral Truvada to a lack of efficacy that we see in FemPrep and in the VOICE trial. I believe this has some important lessons for us. One is that we see that, I think the consensus is that PrEP is a potent biological interrupter of HIV transmission. But what we see is that across different contexts in which it's delivered, it does not have a predictable effect on the populations to which it's been delivered. So it is not enough for these kinds of technologies to simply be delivered into a population. That there may be some synergies between the population to which it's been delivered and the technology which is involved. And we believe these differences are likely, overwhelmingly explained by differences in adherence across the different contexts. But we can't dismiss that there are other factors as well. So this gets us to the idea of prioritizing PrEP across different contexts. So PrEP is a technology that may not be for every person at risk for HIV, And oral pre-exposure prophylaxis comes with high drug costs, high monitoring costs, as well as opportunity costs that come from focusing on this rather than other technologies. So this has given rise to the idea that populations should be prioritized for the use of PrEP, but it's as yet to be fleshed out which populations make the most natural candidates for PrEP. And guidelines by the normative agencies have contemplated that PrEP should be for populations at higher risk of acquiring HIV, but this has been, until recently, not very well developed. Here I cite the WHO guidance and the CDC guidance that was available until last month. And these contemplated that PrEP should be delivered to higher risk populations for HIV acquisition, but were not specific about those. In addition, there is a literature that has discussed provider attitudes and knowledge about pre-exposure prophylaxis. And they have noted that many health providers have a difficult time discussing and recognizing risk in those to whom they provide healthcare services, and have a tendency to contemplate PrEP, particularly in the case of couples in which one member of the partnership is HIV positive and the other is HIV negative. And there's a literature that suggests that PrEP is cost effective in populations for which HIV incidence is at least 2 per 100 person years. But fleshing out what these populations are is something that remains to be done. I'm having trouble advancing my slides. Just give me one moment. Sorry, there we go. However, recently we've gotten more specific guidance from the U.S. Centers for Disease Control in their recently updated guidance on PrEP. They have, in particular, in the case of men who have sex with men, which is the population for which the iPrEx trial enrolled, that they recommend PrEP in the case, or recommend that PrEP be contemplated in the case of HIV negative MSMs who are not in a monogamous relationship with a negative partner and who exhibit a report of a few indices, and that is either insertive or receptive anal intercourse without a condom, a sexually transmitted infection in the previous 6 months, although they're not specific about what type of infection, or that the person is in a sexual relationship with an HIV positive partner. So as I talk about thinking about populations for PrEP, how we're applying this to the iPrEx trial, trying to take two kinds of perspectives, which lead us to two indices for discussing priority populations. The first is the point of view of a provider. And that provider is sitting across someone who is contemplating the possibility of PrEP. And in that case, what we're imagining as a construct for making that decision is the provider trying to understand what is the chance that the offer of PrEP to this particular person will make the difference in the future about whether that person is HIV negative or HIV positive. In this case, they're really trying to optimize the efficient delivery of PrEP to someone for whom it will make the difference in their future HIV status. And this is going to track this kind of index of efficiency. It's going to track with an idea known as the number needed to treat. In addition, we want to adopt a broader public health perspective that is thinking about the rollout of a PrEP-based strategy. and trying to think about what populations need to be reached for PrEP or contemplated for PrEP in order to be able to make a dent in future HIV incidence. And this is going to track with an idea known as the population attributable fraction. So we can imagine that there's a slight tension between these two, because if we only provide PrEP to populations for which it is efficient, we may be able to allocate fewer resources per infection averted, but may have a smaller impact on broad HIV incidence. So just to review, I'll be exploring these ideas about for whom PrEP is efficient and for what populations are required for impact using data from the iPrEx trial. Just a couple of things I want to say about that trial. That was a trial that enrolled 2,499 men who have sex with men and transgender women. It was a global sample that included participants from 11 sites in 9 cities in 6 countries across 4 continents, no less. And it randomized them to receive either daily oral Truvada or a placebo pill. People were instructed to take it every day. People were tested monthly for HIV. In terms of what we used as our indices of the likelihood of HIV acquisition, we had a couple of criteria, including ones that involved numbers of partners, transactional sexual relationships, and anal intercourse without a condom, as well as sexually transmitted infections in the recent time period. I want to explore this idea of efficiency by discussing this index known as the number needed to treat. The iPrEx trial found in the placebo group an annual rate of HIV infections of 3.9 per 100 person years, and in the Truvada group, approximately 2.3 per 100 person years. And that means that if we had followed 1,000 people over time frames of 1 year, 1.5 years, and 2 years, that this would represent the possibility of respectively 16, 24, and 31 HIV infections averted. And this can be translated to an index of efficient delivery known as the number needed to treat. In short, what is the number of people that would have been need to be offered PrEP rather than placebo in order to avert a single HIV infection? So the number that I'm featuring here is that 62, the number of people that need to be given Truvada, or I should say really offered Truvada, in order to avoid a single HIV infection. So that is 62 for 1 year. I will point out that this number needed to treat depends on the time frame as well, and so it tends to decrease over time, assuming that the incidence is common, as well as the benefit of PrEP, which here was 42%, is also constant in time. So I've given you that number for the iPrEx trial, and I've also calculated it for all of the PrEP trials for which efficacy could be demonstrated, and the idea of a number needed to treat is a relevant one. I'm graphing on this the untreated event rate, which is generally the rate of HIV per 100 person years across a series of trials. And on the y-axis, I have the number needed to treat for 1 year. I'd like to point out a few things here. So I have both Truvada and tenofovir trials, as well as the Capriza trial of tenofovir gel in this graph. one thing that is striking to me is how similar the number needed to treat is across the Partners PrEP's arms, the TDF2 trial, and the iPrEx trial. We can see that the lowest number needed to treat is associated with the CAPRISA trial. As you look at those different numbers and see these three contour lines that I've included with the graph, I'd like you to note that the number needed to treat depends on the so-called efficacy, the percent reduction in HIV risk associated with the trial, as well as the rate in the placebo or untreated arm in those trials. So CAPRISA, which had a 39% efficacy, which is far less than the Partners PrEP arms, has a lower number needed to treat than those trials showed. This is because of the very high rate of HIV infection that was seen in the placebo gel of CAPRISA. So even though it does not greatly reduce the overall rate of events, but it does avert events very efficiently. I'd like to point out on the other end of the spectrum, the Bangkok-Tenofovir trial, which again had a higher efficacy than we saw in CAPRISA, but has a very high number needed to treat. And I have, in an attempt to be provocative, included in the green a non-HIV example. This is the example of daily oral statin therapy for the prevention of a first cardiac event, so-called cardiac primary prevention, for whom the number needed to treat for 1 year is approximately 250. This reflects that statin therapy is recommended for populations which have rather low rates of cardiac events, as well as the fact that statins reduce the risk of cardiac events by an amount which is comparable to lower than the percent reduction that we've seen in the statin trials. So we see that this number needed to treat forms a useful index of the efficiency of delivery. Here on this slide, this is just an attempt to make more vivid this idea of the fact that the number needed to treat not only depends on the efficacy by the intention to treat, but also on the baseline rates. So here I've given a hypothetical number of events that we would see if across these different trials we had followed a population of 1,000 of their participants for a 1-year time frame. And so we see that even though Partners PrEP would have averted 75 and 67% of the possible HIV infections in that case, it results in not many fewer HIV infections compared to something like CAPRISA, where we see that we would have averted many more HIV infections for that constant population. So what we decided to do is look at the iPrEx data and not just calculate this idea of a number needed to treat in an overall sense, but explore across possible populations that we could identify within the trial of iPrEx participants. What factors seem to lead to lower number needed to treat, indicating that within iPrEx that we could identify subpopulations for whom PrEP was particularly efficiently delivered. So we focused in particular on the sexual practices that were reported by our participants in a baseline interview at the screening visit, And this is from our face-to-face interview with counselors, not from our computer-assisted structured interview. And in particular, in baseline and sexual practices, where we were interested in whether or not our participants reported anal intercourse in the weeks leading up to their participation in the iPrEx trial, the positions that they report, and whether or not a condom was used. So this rich graph here gives you some sense of the different populations that we've looked at within the iPrEx trial. So in the red are subpopulations defined by reports of anal intercourse by position and condom use. In the black are other sexual practices, and in the green are number of partners. So it's possible with these different subpopulations, possibly overlapping within the iPrEx trial, to look within those populations and calculate what the rate of HIV acquisition was within those subpopulations on the placebo arm. In addition, for those subpopulations in the iPrEx trial, we're able to calculate a number needed to treat for 1 year. So I'd like to go through some of these with you. In particular, in the green, we are seeing the number of partners. The numbers of partners does not appear to greatly distinguish efficient populations. The overall number needed to treat, recall, was approximately 62. So in particular, we're looking for populations that are below that overall 62 number. The ones that appear to stand out are ones associated with the report of a positive partner, a report of a sexually transmitted infection in the 6 months prior to enrollment, a report of syphilis. That is to say, that's not a report of syphilis, that is actually a positive RPR test at iPrEx entry, and reports of receptive anal intercourse without a condom. It is interesting to note that we see a particularly high rate of HIV acquisition in those who entered iPrEx, reported non-condom receptive anal intercourse with a partner who was HIV negative. That was nearly 9 per 100 person years. In addition, they lie on the low contour line, suggesting that there was nearly 70% efficacy within that subpopulation of iPrEx. In addition, we find that participants who reported the use of cocaine in the prior months were also a group that were at a higher risk and thus had a lower number needed to treat. So these represent some of the populations for which we might contemplate that PrEP is an efficient strategy. I want to talk outside the iPrEx trial now and talk about the association between HIV risk and pill taking, as we're seeing in some of the trials in women in sub-Saharan Africa. And here I'd like to point out an observation that when we look across the trials that enrolled women in sub-Saharan Africa. Now here I give the hazard ratio across those different trials. That is the hazard ratio for Truvada if the trial enrolled people and gave both Truvada and tenofovir, as was the case, for instance, in the Partners trial and in the Voice trial. And in trials which enrolled both men and women, I'm giving the female-specific hazard ratio. I use the hazard ratio here because in the case of the Voice trial, we don't have a meaningful efficacy % estimate. like to point out that it appears that across these trials that we see the pattern that higher risk populations, that is running from partners to FemPrep, judged by the overall placebo incidence, tended to be populations that benefited less from the offer of PrEP, judged by an index of drug detection as well as the hazard ratio reported in that trial. That is a so-called ecological association and not considered to be very strong evidence. We see stronger evidence of such a pattern when we look within the VOICE trial. And this is based on some data that was presented by the VOICE investigators at CROI a year ago. And they show that they have two very powerful indicators of HIV risk. These are being less than 25 years of age. We see quite a higher risk of HIV acquisition among those under 25 in the VOICE trial, as well as those who are unmarried compared to those who are married. What is interesting is the tendency that we see there is that the higher risk population, if we look over in the right column, is also a group which has a lower rate of drug detection in the trial. So we're not only seeing the pattern for sub-Saharan women across trials that higher rates of HIV acquisition are associated with lower pill taking, but we see it within the VOICE trial as well. And this is the pattern that we are going to see that is least favorable for identifying priority populations. In thinking about what we need in order to make a public health impact, turn to some of the guidance provided by the modeling data, which I think is really still evolving and has not absorbed all of the results of the trials that have come in. Modeling by its nature is looking at a large number of scenarios, and as a result is difficult to summarize. I would like to point out that there's a consistent theme that's emerged from the modeling, and that is public health impacts for PrEP require good adherence, good coverage of the population at risk, and good uptake by those who are offered PrEP. So as I said, I'm going to pursue these two complementary ideas about making an impact with PrEP. The first was this idea of efficiency. And the idea of efficiency says that we want to enroll populations that are at high risk and likely to highly benefit. But we also want to think about how PrEP can be delivered to populations to have an effect on the population overall. And here, a useful index to contemplate is known as the population attributable fraction. And it's a way of measuring how risk allocates itself within a population. And it is maximized in the situation that we can find a way or a factor that is associated with a higher risk and which is also relatively prevalent in the population. It is a measure of how much of the risk in the population would be reduced if a higher risk group had the risk that is associated with the risk in the lower group. Now, this has been explored in epidemiologic context. It's something that wouldn't necessarily be specific to a PrEP trial, but it's been calculated in a series of contexts for men who have sex with men with respect to the acquisition of HIV. And they've seen consistently high population attributable fractions associated with the number of partners reported, as well as non-condom receptive anal intercourse, which I denote here NCRAI. In addition, I'm able to calculate it based on the available data for the VOICE trial. And for instance, being unmarried is associated with a population attributable fraction of 83% in that case, and age less than 25 is associated with a population attributable fraction of 58%. So in other words, if unmarried women carried the same risk of HIV acquisition as married women, we would see 83% fewer HIV infections in the VOICE population. So I'd like to illustrate the calculation of the population attributable fraction by using data from the placebo arm of the iPrEx trial, using the report at the screening interview on sexual practices of non-condom receptive anal intercourse. So we can stratify our participants at the time that they enroll in iPrEx into one of three categories. Those who report either no anal intercourse or anal intercourse that involved a condom with all partners in the weeks prior to enrollment. That's 14% of our participants in whom we observed 3 HIV infections during the follow-up of the iPrEx trial. 25% of our participants reported that they had had anal intercourse without a condom, but only as a top. That was 25% of our participants. 8 HIV infections with an annual rate of 1.5 infections per 100 person years. 60% of our participants reported that with at least one partner they had receptive anal intercourse without the use of a condom in the 12 weeks prior to enrollment at iPrEx. That represented 72 follow-up HIV infections for a rate of 5.4 per 100 person years. So to measure how much of the population attributable fraction of HIV on the placebo arm is associated with NCRI, we can just advance, and here as I toggle, I'm taking that rate of 5.4 in the highest risk group, making it to be the same as in the lowest risk group of those who reported that they used a condom or did not have anal intercourse. If they had had that rate, instead of seeing 72 HIV infections, we would have expected in that population to see 16 HIV infections. And we would have averted 56 out of the 83 total HIV infections seen in the placebo arm, or 67%. So here I both illustrated how we think about the population attributable fraction, how we calculate the population attributable fraction, in addition to showing that the report at the enrollment visit in iPrEx of receptive anal intercourse without the use of a condom is associated with a quite high 67% of HIV infections. So we have these two ideas in terms of prioritizing populations: efficiency as well as impact in delivery. One, the first capturing the perspective of a provider looking to make, for each offer of PrEP to be averting as many HIV infections as possible. And I stress here that really it's an offer of PrEP, and one that has built in all the possibilities of non-adherence that we saw in the iPrEx trial. This is really an index that tracks with cost effectiveness. And the second point of view that we're adopting is this idea of the population attributable fraction, thinking about populations that can be offered for PrEP and what the potential impact of a strategy that prioritizes those populations. One that's really taking a public health point of view. So here is the figure, which I think is kind of the money figure, the real point of the paper that Susan Buchbinder wrote and is now hopefully in your hands. And it's graphing on the y-axis the number needed to treat with subpopulations in the iPrEx trial. And on the x-axis is the population attributable fraction. Here we're looking at those same subpopulations that you saw on a graph before, but now we're explicitly looking at the trade-offs between efficient delivery, as represented by the number needed to treat, as well as potential impact by looking at the population attributable fraction. So we can see that there are a number of factors that are associated with an efficient delivery of PrEP. And one way we might measure that is by looking at the dashed line that runs across, which is the dashed line associated with the 62, which was the overall number needed to treat in the iPrEx population. So any of those dots which lie below that are populations that were more efficient than the overall iPrEx population. We see, for instance, that reports of cocaine, receptive anal intercourse without a condom with an HIV negative partner, as well as with a positive partner, syphilis, all associated with very favorable number needed to treat. These are populations for which the iPrEx data indicate that PrEP could be efficiently delivered. But note that many of these are rather limited in their population attributable fraction. For instance, receptive anal intercourse without a condom with an HIV positive partner in the iPrEx data is associated with an efficient number needed to treat, but a population attributable fraction of around 1%, suggesting that while offering PrEP to the negative partner in a positive-negative relationship is an efficient strategy for a provider to deliver PrEP, it's one that's unlikely to have a broad public health strategy. I would say that this does reflect some of the nature of the iPrEx trial, which enrolled people in contexts in which HIV testing might be low, as well as rates of HIV disclosure. The two standouts that we are seeing in terms of having a low number needed to treat and a higher population attributable fraction are receptive anal intercourse without a condom with a partner of unknown serostatus, or if we take receptive anal intercourse without a condom and combine across the serostatus. So this suggests from the iPrEx data that a relatively simple asking of someone, have they had receptive anal intercourse without a condom in the prior 12 weeks, is associated with both an efficient strategy and one that could potentially have a broad public health impact. So non-condom receptive anal intercourse is the overwhelming factor we find associated with optimizing both indices. In fact, people may recall from a close reading of the iPrEx data that when we looked at subgroups of efficacy, that all of our efficacy resided in the 60% of our participants who reported non-condom receptive anal intercourse at entry. And when we looked at the other 40% of our participants who reported either only insertive non-condom or no anal intercourse without the use of a condom, we did not see any lower rate of HIV infections. So the iPrEx data strongly indicates that non-condom receptive anal intercourse is the real opportunity for PrEP. I also want to again draw attention, because the literature has suggested that providers contemplate PrEP for um, positive, negative HIV partnerships, that while this is efficient, it may be associated with low population attributable fractions. I want to point out that while this may be surprising to people, that we did not find that transactional sex, and in our case that was the exchange of sex for money, shelter, or drugs, was not a risk factor for HIV infection. But the iPrEx study is a global study conducted across Asia, Latin America, the US, and South Africa. So this has both strengths and weaknesses. For instance, we find that substance use was not consistently associated with HIV infection, and substance use may be contexted. It's very important perhaps in the US, but not necessarily broadly applicable within the iPrEx trial. So I think at this point I've kind of discussed this more thoroughly than I did at Croy, and I'm happy to take questions and points of discussion at this time, if that's possible.
Thank you very much, Dave. It was an excellent presentation, very didactic. In fact, you didn't just focus on comments about the iPrEx trial results, this additional analysis of the data, but you took into account very valuable data from other trials, and particularly trials in other populations. So I think this, at least to me, it has been extremely useful to hear to this kind of analysis. And so what I would do now is to well, first announce that this presentation is being recorded, and we are going to post the recording in our website very soon. Second, I wanted to thank WHO, particularly Kevin O'Reilly, Rachel Bagley, Catherine Curran, because this initiative has been possible through collaboration with the World Health Organization, and also the Gates Foundation, which supported the grant through which WHO has been participating in this collaboration. And third, I would before actually reading some of the questions that we have been receiving for you, I would ask Kevin O'Reilly, who has been participating here on behalf of WHO, to give us some to tell us WHO's point of view with regard to this collaboration. So, Pedro, could you please let Kevin speak?
Hello, can you hear me? Hello?
I know I can hear you.
Can anybody? Okay. Some people can hear me, good. Then I'll start talking. I would really have much preferred to speak before Dave gave that excellent presentation, because it's very difficult to follow on the type of analysis and the type of wisdom that he brought to this. I think it was very impressive, and I saw it at Croy, but I enjoyed it even more this time. So keep it up, Dave. Every time it gets a little better. I like the way that you focused the analysis around using the NNT for helping a provider figure out what makes most sense versus the population attributable fraction for looking at what makes most sense in a public health context. And I think the challenge we all have in the future is going to be, particularly those of us who work with the normative agencies, is to figure out how we balance those two things. And but I think you've given us a lot to think about. I also want to put in a word of endorsement for Carlos and Pedro in the work that they have been doing. I'm sure you've all seen the beautiful website that they have put together, which is out there and available. And I need to stress maybe not the name NEMUS, but the N in NEMUS, which is the network part of it, because this is really their attempt to develop a network that is going to be beneficial for everybody who is interested in doing work on PrEP or doing work on PrEP currently, and those of us who are standing by the sidelines watching people who are doing work on PrEP. And this webinar is a great example of the type of work that they can help bring to the fore. And it also, I think, is an opportunity for all of us to treat this like a network and try to give them suggestions of what our needs might be and how they can possibly help us to meet them. So we're pleased to be supporting this activity, and we're also very pleased with the way this is starting off with the efforts of Carlos and Pedro. And now I'd like to turn it back over to people with more substantive questions to ask.
Thank you very much, Kevin. Really appreciate the great support that we have received from WHO for this effort, and we really hope it's going to bring the discussion, particularly where it hasn't really been happening. As a matter of fact, Vincent Dewey let us know that in France, particularly through the efforts of SIDAction, a lot of this discussion has also been taking place. However, that's not the case in most of Latin America, Africa, and Asia, and other parts of Europe too. So really, our idea is to help a global dialogue start through a networking effort. Anyway, as I was saying, there are a few questions that people have asked. I think the first, David, came from Vincent. He was asking about your slide number 17, and what the population of reference was there. It's a slide that talks about a population of 83, 83 people. Yeah, that was one question. Maybe we can, I can mention the other questions now too, to make it easier. Yeah, let me check to find, yeah. I think, okay. There's, Stephen asked, do you know that persons who reported not condom receptive anal intercourse at enrollment continued this behavior or made some changes and returned to this behavior? That's one question there. Then Juan Guanira asks, why non-condom receptive anal intercourse in last 12 weeks? Is that an entry criteria for iPrEx? I think we have two more. I mean, but let me check, because we are close to the end of the hour.
Yeah.
Deirdre Grant, thanks for a great presentation. Wondering how we might apply this data for programming. How can it be applied, disseminated, translated, especially in light of a whole new set of guidelines from CDC? And finally, Jim Pickett, I wish all providers had to listen to this presentation. We still see so many of them who will only consider PrEP for serodiscordant relationships, and for no one else. It's really maddening. Okay, so Dave, please.
Sure, so in terms of slide 17, there's a particular question about what the reference population. So slide 17 is focusing on participants randomized to placebo in the iPrEx study, and the reference group is those who reported either that they had no anal intercourse in the 12 weeks prior to enrollment in iPrEx, or that any anal intercourse they had used a condom. That's that particular case. Juan, hello Juan, great to have you on. In terms of the question about the previous 12 weeks, the counselor interview in iPrEx, when asking about sexual practices in the face-to-face interview covered the previous 12 weeks as recall. In terms of how we apply this for programs and for the delivery of PrEP, I think this complementary to Jim Pickett, hi Jim, comments, and that is, I think it's important to have a message reach providers that with a couple of questions, do you have sex with men, women, or both? Are you the receptive partner? Are you ever a receptive partner without the use of a condom? Is enough of a question to pick up a great swath of men who have sex with men, who carry a burden of HIV infections, and for whom the delivery of PrEP is one that is efficient. I think efficient by the standards of the iPrEx trial as well as what we see with statins. Just to echo, Jim Pickett is zeroing in, I think, which is the strongest single thing coming out of this presentation, the centrality of NCRI, and that we need to move providers away from thinking about PrEP only in the case of known HIV positive, HIV negative sexual relationships. And this is where I urge people to read Jared Baton's commentary, where I forget the exact sentence, but he beautifully summarizes this dilemma, that if providers are really only thinking in that context, then we are under-delivering the potential of PrEP as a prevention strategy.
Last question. I think everything is really extremely important. Now, one of the key concerns among many people would be actually the capability of the population, particularly those who are not using condoms now and naturally would be candidates for PrEP, the capability of this population to adhere to PrEP. No, and I wonder if the data, as they have been collected now, would be able to help us respond to this question at this point. I don't know what you think.
Yeah. So what I would say in this point is encourage you to look forward to more data from iPrEx. There is a manuscript under review with a medical journal that explores factors associated with drug level detection in iPrEx. In addition, we are moving forward with iPrEx OLE and its analysis, and we'll have better data in characterizing factors associated with adherence in the open label extension of iPrEx than we've ever had before. We have better assays, better sampling, better numbers. So I think that we'll be able to speak to this. Our indications will remain consistent, that those who report higher risk practices, those who are basically at higher risk of HIV infection among those that we have studied, tend to be those who use PrEP more consistently.
Dave, thank you so much for this excellent discussion. I think it's extremely useful to start having the discussions now, and our presentation today with you has been a very good way to start our webinars. So I have to, besides thanking you, I have to thank WHO, Kevin, Rachel, Bagley, Catherine Curran, Papa Salif So at the Gates Foundation, our colleagues in the networks, definitely for their enormous support to get this going and to have many people learn about this effort and join today. And actually announce that our next conference is going to be the next one is we're going to alternate English presentations with presentations in Spanish and French and Portuguese. So the next one is going to be in Spanish on June 12th at the same time. And then by the end of June, we're going to have a new one in English, and we'll let you know as soon as we confirm the speaker. So please stay tuned. So again, thank you all very much for your participation, and we'll keep in touch. Thank you, David.
Thank you, Carlos, and thank you, Pedro.
Thank you. Take care. Thank you very
Thank you.
much. Bye. Bye.